Hello friends, let's enjoy the chest radiographs with Dr. Y. I am Dr. Y, chest radiologist and medical professor in South Korea. Session 30, AP Supine Chest X-ray. Today I'll explain the difference of PA erect film and AP supine films, and will show you several real cases of AP supine radiographs. Let's start this session with these two films. How do you feel with this left side film? This is chest PA erect film. Normal, healthy, young man's, without unusual, abnormal findings. Feel comfortable, something like nice picture. But how about this right side film? This is AP supine film of the old man's in ICU. How do you feel with these findings? Uncomfortable, uneasy, unclear, and somewhat embarrassed how to explain these findings correctly. The problem of AP supine view is image quality is poor for correct diagnosis. That's it. That's the point. What is AP supine chest radiograph? It is for the patients who cannot stand up, someone like ICU patients or who is unconscious. So the result is lesser film quality for diagnosis. And AP erect view is the quality is best. It is for the pediatric outpatients. And PA erect view is with best quality, the gold standard which we are very familiar with. I'll explain you the difference of AP supine film with PA erect view. Patient condition is poor, usually poor. Patient position is also poor. And clavicle is upwardly moved. Scapula is inward, inside the thorax. Rib becomes more horizontal. The thorax length is shorter than PA erect view. Heart size is bigger. Margin is fuzzy. And mediastinum is getting wider, and paraspinal stripe is also wider. There is one more issue on AP supine film, that is gravity. Gravity works differently with supine view and erect view. The gravity is from front to back, anterior to posterior in supine AP view. But in erect view, the gravity works from top to bottom, upper to lower. That is big difference with AP supine view and PA erect view. Let's think about the mass weight. Fluid is much heavier than lung tissue, and lung tissue is also heavier than air. Let's focus on gravity on AP supine view. One is pulmonary vessel size. We call it cephalization. In AP supine view, upper pulmonary vessels are getting bigger than PA erect view, and lower pulmonary vessels are getting smaller than in PA erect view. And second is the azygospan. Azygospan normally become congested in supine view due to gravity. So sometimes we are confused with normal azygospan as for our lymph node enlargement. Let's find out the real difference of AP supine film findings with PA erect view. These are same patient with 1 day difference. Young, healthy man. Both images are beautiful. Beautiful, normal findings. What's the difference? First, clavicle is upward, and scapula is inward. Ribs are more horizontal. Mediastinum is wider. Azygos vein is prominent, something like 4 lymph node enlargement, big. And heart is bigger, with a little fuzzy margin. And paraspinal stripe is wider, and the thorax is shorter. Upper lobe pulmonary vessels are bigger, much bigger than PA erect view. These findings are the difference with PA film. Let's review the gravity direction effect on the real clinical issue, real practical issue, according to the gravity direction. Lung lesion, true pulmonary lesions such as pneumonia and cancer have no real impact according to the gravity direction. But pneumothorax, pleural effusion, pneumoperitoneum, pulmonary vessel size, azygos vein, 4 lymph node enlargement have impact affected by the gravity direction. Let's enjoy the real cases of AP supine view with pulmonary lesions, which will not be affected with gravity direction. This is AP view. What do we see? Although the film quality is poor, we see something large, something homogeneous density here, not obscuring heart border. That means this lesion is very dense, very homogeneous, and retrocardiac location, not anterior location. What's the difference with this PA image, PA erect image? Same, almost same. Only the difference is image quality. Better image, lesser image quality. The answer is left lower lobe large adenocarcinoma with small pleural effusion. This lesion does not affect it with gravity direction, whether from up to down or from front to back, just left lower lobe location without touching heart border of anterior location. How about this second case? It is of pneumonic consolidation. 1 day difference. Only 1 day difference with almost same findings. What about the AP supine film? Heart border, right heart border is obliterated, maybe right middle of lesion, with mild air bronchogram around right heart border. And we see another airspace consolidation, retrocardiac, air bronchogram, diffuse consolidation, not touching heart border, so retrocardiac, left lower lobe consolidation. And we see the aorta obliteration, paraspinal line obliteration. This means all air bronchogram consolidation of left lower lobe. How about this? How about the findings in PA erect view? Yes, almost same. Mild right heart border obliteration with consolidation, and left lower lobe air bronchogram with consolidation, retrocardiac location, and mild irregularity of diaphragm. That means both lower lobe are involved, or small pleural effusions are present. On this axial non-contrast lung window setting CT, we see partial airspace consolidation of right middle lobe medial segment, obliterating, obscuring right heart border, and small GGN consolidation in right lower lobe, and airspace consolidation in left lower lobe, obscuring aorta border, not obscuring left heart border. These findings match with this AP supine film. This third case, AP supine film findings are well matched with the axial lung window setting CT. This is ARDS. Let's check it out. Intubation, diffuse, right lung and left lung, hygienist, GGO, and consolidation with air bronchogram with traction bronchiectasis. More consolidated area in left lower lobe with a diffuse finding of ARDS. How about NCT? Yes. Heart is a little enlarged with pericardial effusion, diffuse bilateral GGO with air bronchogram with irregular dilatation showing fibers of traction bronchiectasis with minimal small pleural effusion. This is compatible with ARDS. This AP supine film of lung pathology shows exactly same as CT or maybe PA erect film. I have told you that the pleural effusion is usually affected by the gravity direction, but this is an exception because this is loculated pleural effusion. Loculated pleural effusion does not be affected with gravity direction. Yes, left side. Homogeneous, increased, irregular margin, density. Homogeneous density means usually fluid, and this irregular margin means it can be exudate or loculated. Let's check it out with the PA erect film. Same finding, almost same finding, encircling left chest thorax and lower lung zone. These are loculated pleural effusion. Same findings with a different image quality. This contrast-enhanced axial CT explains everything about that chest AP view findings. Loculated anteriorly, posteriorly loculated pleural effusion. And this does not be affected with gravity direction from anterior to posterior up to down direction. It is loculated, non-movable structure, so not affected with gravity. From now on, we will enjoy the cases which are affected with gravity direction. So the AP supine view finding is different with PA erect view findings. First case is pneumothorax. We are familiar with inspiration film and expiration film of a right side pneumothorax. Air is on the top, above the right upper lobe, here, and here even in expiration film. Yes, and there is a small air fluid level here. Fluid is downside. Air is light, so air is up. This is gravity-dependent findings. We know that when we are in supine position, the lower lobe anterior side is usually higher than the upper lobe side. This lower lobe anterior portion is higher than the upper lobe in gravity perspective. So in AP position, we usually see the pneumothorax here in the down lower lobe, below the lower lobe. We call this sign as deep sulcus sign. It is more easy to find out the pneumothorax here than the apex. But in erect PA view, the air is light, so the air is up at the top here and fluid is here down and fewer smaller gas in lower lobe side, large gas in upper side. So this we see air fluid level here, fluid is heavier than air, and air is lighter than fluid in apex. So in PA erect view, pneumothorax is here, but in AP supine view, pneumothorax is here. This is deep sulcus sign. Have you noticed another pneumothorax in left side? This one, this one, this one, this one. Bilateral pneumothorax, one-day difference. ICU patient, supine AP view. Yesterday, it was okay. Today, what happened? Pneumothorax here. Not at the top, but at the lower lobe area. This is pneumothorax in AP supine view. This is an exercise. ICU film. Supine AP view. You got it? Yes. Deep sulcus sign with actually mark band effect here and here. Deep sulcus sign with left lower lobe collapse. Air bronchogram. One of the most annoying findings of AP supine view is pleural effusion. Pleural effusion with or without consolidation or partial collapse. That is the most annoying problem in clinical practice of AP supine film. Let's check it out. Let's go first with this one. One-day difference, almost same finding. This is erect view. Large pleural effusion, right side, less amount on left side. And right lower lobe is collapsed with residual air bronchogram here. Yes, this is the answer. And the above area, both side lungs are clear. No problem with normal pulmonary vessels. What about the same patient in AP view, AP supine view? Yes, diffuse haziness of pleural effusion. But how do we know this is pleural effusion or air bronchogram of consolidation? Yes, that's it. Pulmonary vessels. Although we are looking at the bronchogram, if we see the pulmonary vessels here and there, that means lung is relatively okay. If we see the pulmonary vessels, I say you once again, if we see the pulmonary vessels in AP supine view, the lung pulmonary parenchyma is relatively okay. So this is more likely to be diffuse large amount of pleural effusion. Don't pay attention to the left side. We'll disregard this one. Just focus on this pleural effusion on right side. Right lower lobe is collapsed like this. Let's confirm once again with this magnified view. This is the most important slide of this session. Pleural effusion in AP supine film. Yes, right lower lobe is passive atelectasis. Yes, let's disregard this one too. Right middle lobe and right upper lobe is okay because we see pulmonary vessels. Pulmonary vessels are intact, means around the pulmonary vessel, the lung parenchyma around the pulmonary vessels are okay. If consolidation is present, if this is a consolidation, we cannot ever see the pulmonary vessel here. So, pulmonary vessel here, the lung will be okay. That is most important finding of AP supine film. Let's repeat again. Be confident with the second film of another patient. Right pleural effusion. You are confident about the pleural effusion here on the right side. Right pleural effusion with intact normal right lung. Normal right lung with pulmonary vessels alive. And let's check it on the left side. Left pleural effusion with CP angle blunting in erect view. Here, how about what happened on AP supine view? Diffuse haziness with evident pulmonary vessels. Let's confirm in the magnified view. Do you see the diffuse increased opacity on the left side? Clear in erect view. Diffuse increased opacity in supine view with alive pulmonary vessels. Yes, this is pleural effusion on left side. How about this case of bilateral pleural effusion with both lobe passive atelectasis with pulmonary edema? Let's check it out. Edema. Everywhere edema in erect film. Subsegmental atelectasis with both lobe passive atelectasis with bilateral pleural effusion. What happened when he's on supine view? Both heart margin is clear. That means this hazy increased density is not in anterior location. That is the one reason the possibility of pleural effusion is high. Diffuse haziness with minimal air bronchogram with bronchovascular thickening, diffuse haziness, and air bronchogram with many alive pulmonary vessels. Pleural effusion with passive atelectasis of both lower lobe. Let's confirm with the axial lung window setting CT. His heart size is normal, and bilateral his anterior lung is very okay, without only mild pulmonary edema. Let's go back to this AP view. Bilateral heart border is okay. This means his anterior lung is okay. That also suggests the less possibility of lung lesion. Diffuse lung lesion possibility is very low. And look at the pulmonary vessels here and here and here and here. So, although the density are very extensive and severe here, most of the density are from pleural effusion, not from lung parenchymal consolidation. That's why the heart border is so important in AP supine view. If heart border is okay, the lung seems to be normal. This is the point of this slide. Isn't this pleural effusion findings interesting? I'm very interesting. Let's review the last slide of pleural effusion. Let's go. We are now confident that this right side diffuse haziness is from pleural effusion. Pleural effusion, not from lung, not from lung. Let's go to the left lower lobe. This is a bronchogram of dense consolidation of retrocardiac location, so it is left lower lobe consolidation obliterating aortic border, same as on erect PA view. Pneumonia is same. Pleural effusion is different with AP supine view and PA erect view. It's interesting. Don't you see? Let's enjoy again the intact bilateral heart border in AP supine film of diffuse haziness. And this suggests more likely to be pleural effusion than diffuse lung lesion. Yes. Now it's almost done. Let's go to the last session. Free gas, pneumoperitoneum. The number one examination for diagnosis of free gas is chest PA erect film, not simple abdomen film, right? Yes, this one. Free gas. Air fluid level in stomach. This is erect PA film of pneumoperitoneum. What do we see here in one-day difference? AP supine view. Nothing. Nothing. It's just looking normal. Looking normal. That's the dilemma or problem of pneumoperitoneum in AP supine film. But sometimes we meet pneumoperitoneum, like this patient in AP supine film, when the gas amount is large. Right subphrenic gas here, and we see the outer wall of stomach and colon. That means gas outside the bowel. This is free gas pneumoperitoneum. Sometimes we see this one. So I suggest everybody, including me, if we are possible, just take the film, PA erect film, not AP supine film, if possible. Try to take the film of a PA erect film. That is more beneficial for the patient and for us. How did you enjoy the topic? The AP supine chest radiograph. Was it interesting? Funny? I hope so. Like, subscribe will be a big support to Dr. Y. Thank you very much and have a good time.